Good morning, everybody. This is Kroom Lawrence with Hemostemix. I'm Chief Commercial Officer, Head of Patient Care. Welcome to VesCell Health Talks number 16, New Approaches for Diabetic Wound Care and Limb Preservation. This is a discussion designed mostly for vascular surgeons and their patients with chronic limb-threatening ischemia. We're so thrilled to have you. This is our 16th in a series, and we're covering essentially an exciting time and a transformation of care, bringing angiogenic cell therapy forward to transform care forever, shifting between sick care and advances that are exciting. We're going to cover clinical data and applications of stem cells and lots of content like that. And recapping a lot of conversations we've had with vascular surgeons and their patients over the last several months and, frankly, years. Hemostemix is a stem cell platform company that's had 20 years of clinical development, and so we're excited to bring that to you. So we're covering today the vascular crisis, specifically around diabetic foot ulcers and the risk of amputation, how we can change that trajectory. We're going to talk about regenerative solutions, cell therapies that can address gaps in care, how to administer ACP01. Those are our angiogenic cell precursors that can restore blood vessels, what treatment administration looks like, what safety monitoring looks like, and then finally what patient access looks like. So the goal of this training and this presentation today is to really equip Florida-based vascular surgeons with comprehensive guidance to safely and effectively administer ACP01 in their clinical practice. And this is key based on our clinical trial protocols established over the past several years. And so why Florida? So Florida has passed Senate Bill 1768 that has provided a pathway for physicians and patients to access care. We're going to get into that more in a moment. But there are other ways to access care of our stem cell therapy. And so we look forward to all of your questions. Please place questions in the chat, or if you'd like a follow-up, simply put follow-up, and I'll know to get in touch with you after the discussion. We are live streaming across numerous platforms in the US and Canada and around the world. We are good on all channels, and we're grateful you're here. So let's dig right in. This will be actionable for all audiences. But first, let me mention a couple of key terms that we're going to be discussing today that really make up the definition of precision regeneration. Angiogenic cells are a particular type of cell that Hemostemix specializes in that helps restore blood flow. We're going to talk more about that. Autologous cells are stem cells derived from your own blood. There's a particular safety profile that we're going to cover in a minute that's grounded in 7 of our clinical studies with ACP01. So we're going to be talking about the isolation of these cells from your own blood using our proprietary technology, the angiogenesis activation, that's the formation of new blood vessels that can improve circulation, especially to oxygen-starved tissue that has been impacted through diabetes and atherosclerosis and conditions like that, inflammation reduction, pain reduction, paracrine signaling, the release of growth factors that activates the body's natural repair mechanisms, and then targeted delivery, how the ACP cells home into the site of ischemic disease and deliver the regrowth of blood vessels, thereby bringing forward the healing capability. So we're going to talk about that in a moment. Hemostemix, very quickly, is a Canadian-based, publicly traded company that really is the pioneer of autologous angiogenic stem cell therapy, a company founded in 2003, a winner of the World Economic Forum Technology Pioneer Award. Hemostemix has a patented scaled solution on blood-based stem cell therapy under the name VesCell, which is ACP01. 7 clinical studies of 318 subjects. and advancing several phase 1 and 2 studies covering a range of ischemic diseases from pain, angina, peripheral arterial disease, chronic limb-threatening ischemia, ischemic cardiomyopathy, non-ischemic dilated cardiomyopathy, congestive heart failure, total body ischemia, and vascular dementia. We often cover the clinical study data on these calls, and you'll get a sense for how the cells work, as mentioned, as they home into the site of need, restore blood flow, and then activate the healing process. We're going to go about 30 minutes today, and we look forward to your questions. There are important treatment disclosures that we need to cover. ACP-01 is investigational. It is not FDA approved for commercial use, but it is available in states like Florida for pain and wound care under very specific state regulations. There are global access points through trials and compassionate use programs. Patients are required to have informed consent with their physician. Treatments are likely out of pocket. We're going to talk about access in a moment. And please always consult your healthcare provider before making any treatment decisions. Nothing in this deck does constitute medical advice. There are a range of resources that we provide for our community. And so you're seeing them here. Number one is the Florida Senate Bill 1768 itself. We encourage everyone to read it and understand it. Those are the guidelines that we live by in that state. We will talk about our clinical studies, our poster at the Society of Vascular Surgery that was the keynote. We'll talk about our phase 1 and 2s. There are also web resources. Yesterday we had, we think, a phenomenal Grand Rounds event with a number of vascular surgeons. That presentation is now available, and we think it's a very solid summary. We'd encourage everyone to take a listen. You can find it on the Hemostemix channel on YouTube. We also offer a patient consent form, ACP-01 treatment guide, so you really have everything you need to consider this therapy for your no option critical limb threatening ischemic patients. And then finally, congresses. Where are we? Going to the American Limb Preservation Society event, Society for Vascular Surgery in Southern Florida, Wound Care Innovation events coming up. But we will see you out there at the congresses, and we hope you'll swing by our booth. And we look forward to all of your questions so that we can form a community and build momentum around transforming care. The vascular crisis behind diabetic limb-threatening ischemia is well known, but what we were even discussing just yesterday is the increasing incidence. There are more and more patients presenting with later stage disease, stage 3 and stage 4, requiring stage 3, stage 4 interventions. And it's a silent disease, and so patients may not be aware until they show up with a wound that won't heal, and their podiatrist is then activated to figure out what is the best path of care. If the podiatrist is unable to solve the wound, often they're referred to a vascular surgeon for more advanced treatment. And so often the vascular surgeon is a natural ally for us, who will, if the patient, and about half of them are not candidates for revascularization or stents, those patients now have a new option in the state of Florida and other places around the world, and we hope you will consider some of the information we're sharing today. We start off with microcirculation, the unsung hero of healing, where healthy microcirculation delivers oxygen, nutrients, and immune cells. It's the healing pathway for tissue repair. But in the case of diabetic impairment, hyperglycemia thickens vessel walls, slashing blood flow to wound sites. And so the poor microcirculation can triple amputation risk. Restoring flow predicts healing success. So we are focused on restoring flow, which is key to healing, not just treating the symptoms. So ischemia and pain are also correlated. Atherosclerosis creates dangerous arterial bottlenecks. The result is essentially a chemical buildup that acts like an internal burn that activates nerve endings and sends continuous pain signals to the brain. And that is an alarm that tissue is dying. And so we talk about the shift from normal aerobic metabolism to ischemic anaerobic crisis, where cells are shifting to an emergency mode, and this process produces energy and floods tissues with toxic lactic acid that then creates the pain. And so that understanding that mechanism of action is important to understanding treatment. There are potential limitations in current wound care. At the Congress and events, there are lots of innovative solutions, but essentially there's not been a transformation in care for wound debridement of dead tissue, pressuring, offloading with boots, antibiotics for infections, glycemic control, and there are still persistent gaps in care. 12 weeks average healing time, high recurrence rates, little to no vascular regeneration, and then of course very late stage diagnosis of peripheral arterial disease itself. These are all factors that complicates the lives of podiatrists and wound care professionals. And so now let's talk about regenerative solutions. And in our case, ACP01 is investigational as an autologous stem cell therapy. That means that's from your own blood that helps treat ischemic diseases in many forms in the body. The mechanism we've talked a little bit about, using angiogenic cell precursors to migrate to injury sites, promoting new blood vessel growth, reducing inflammation, enhancing tissue repair. We have a range of safety studies for ACP01, 7 studies with 298 patients, 7 studies published. There was 1 death that is not believed due to the cells themselves, but due to an unrecognized silent myocardial infarction in one of the patients. And we can talk a little bit more about that in a moment. But essentially here we have studies in angina, cardiomyopathy, heart failure, and then also critical limb-threatening ischemia, the 3 on the right. So Szabo, Henderson, and Multiranga cover our phase 1 and phase 2s, open label with 20 patients, open label with 47 patients, then Multiranga, open label randomized with 6, and we'll talk a little bit about those now. The overall safety profile, and I'll just refer to our Chief Medical Officer, Dr. Fraser Henderson, and even his roundtable yesterday, covered off on a safety profile for the autologous stem cells. Remember, there are patients' own stem cells, where it is a simple blood draw. It's an in-office procedure with no anesthesia required, no complications associated with bone marrow harvest. There's also a general public perception of safety relative to autologous stem cells. Why is that? Because it's your own, from your own blood. Those are your own cells, right? So there's no risk of tainted blood, no parasites or viruses or pathogens, no risk of neoplasia from pluripotential cells, and no ethical concerns with fetal tissue that comes up. And one of the big ones is no transmissible spongiform encephalopathy, a Jakob-Creutzfeldt's disease. It's a very, very, very small risk in other stem cell forms, but not in autologous stem cell forms, which again are from your own blood. This is one of the posters from 2023 presented to the Society for Vascular Surgery. It's a great overview that talks about what are the ACP cells, what are the methods of administration. You'll see some photography of wound healing over time on a very small sample, and I'd like to cover off on some of that data now. But it's a great study, and it's available for everyone on the call to read. So we're going now to let me just say a couple of words on that study and combined with this phase 2 trial. So essentially there's and this is investigational small n, actually an n of 21, a 93.5% ulcer healing rate, ulcer size reduction from 1.46 centimeters to 0.48 millimeters. That's about the size of a strawberry to about the size of a grain of sand in this study. The amputation rate was 4.8% versus placebo of 25%. The mortality rate was 4.8% versus placebo of 12.5%, where the wound healing persisted through visit 6 and visit 7. and we've covered this data here. Again, just to repeat, amputation and deaths within 12 months, ACP01, sample size of 21, 4.8% amputation rate, 4.8% death. Placebo, Innovate, 25% amputation, 25% death, where the placebo really is in alignment with U.S. Medicare studies showing around 15% amputation and 20% death. And this is for patients with late-stage peripheral arterial disease, critical and threatening ischemia, who had wounds that would not heal, who are at risk of amputation. And so this is the data from that phase 2 reexamination study. I'd like to now cover the administration of ACP01, and there's a lot of detail that we're going to review here. It's important to talk about this so vascular surgeons can understand every stage of safe administration in the clinical trial setting or in the commercial setting. And we basically are using the trial protocols to align how we are instructing and training vascular surgeons to qualify, administer, and monitor patients that are deemed appropriate for this type of care. So let me just cover a couple of the high notes here because this is important. So our objectives are to determine the efficacy and safety of intramuscular injection of ACP01, that means into the calf itself, containing blood-derived autologous ACP, autologous cell populations, in subjects with critical limb ischemia who are on standard of care therapy and who have no endovascular or surgical revascularization options. We understand that's about half of patients that are at that late stage. They're not a candidate for revascularization or stents. And previously, physicians would say, I'm sorry, patient, there's nothing else we can do. And so now we have an opportunity to talk about an investigational study. The primary endpoints from our previous phase 2 study that we'll use as guidance for both our future clinical and commercial pathways. The primary efficacy endpoint will be the earlier time from treatment with ACP01 to either de novo gangrene or doubling of wound size or major amputation or death. Primary safety endpoint, safety of the intramuscular injections of ACP01. Secondary endpoint, change from baseline in the VAS pain score, change from baseline in ulcer size. This is, to repeat, an investigational medicinal product. The active substance is a mixture of autologous ACPs consisting of at least 5 million cells with a maximum cell volume of just around 200 million. They're from the patient's peripheral blood, cultured ex vivo under sterile conditions in our best practices clean room that is FDA regulated. You'll receive 6 separate syringes, 5 milliliters each, for 30 injections total, up to 24 in the calf muscle, 6 in the foot, using a 23 gauge needle. We can talk about more of those details as we dig in. The patient inclusion and exclusion criteria is very important. I'm not going to hit all of these, but essentially the core requirement that patients are diagnosed with chronic and threatening ischemia per task 2. That means chronic ischemic rest pain, ulcers, or gangrene due to proven arterial occlusive disease with hemodynamic indicators of severe PAD, and not a candidate for revascularization, and then on standard of care with hyperlipidemia control, hypertension control, antiplatelet control, and hyperglycemia control. For patient exclusion criteria, there are quite a few here, and I'm just going to hit a couple, and these are very important. So if a patient has a prognosis requiring major amputation within 4 weeks, they should be excluded from care. If they have advanced CLI with severe ischemic ulcers greater than 10 centimeters squared or dry gangrene proximal to the metacarpal joints or wet gangrene, they can be excluded. Untreated active lower extremity infections, low body weight, renal failure, hepatic failure, anemia, or other severe concurrent diseases. We can cover more of this as we meet to discuss the safe and effective administration, that makes sense in your clinic. The screening periods are important. So days 30 to up to the administration themselves, there needs to be important screening, the VAS pain score, analgesic types, physical exams, vitals, leg assessments, blood pressure, ulcer assessment size, blood tests, into the processing and administration of the cells, where all enrolled patients in our poster received 250 cc's of peripheral blood drawn. So that was the initial blood draw that was sent then to the core laboratory for processing. The cells then are re-injected 7 days later directly into the designated leg, and then patients are followed up post-treatment. And so you'll see the markings on the calf muscle itself, 24 injections, 1 centimeter deep, and 1 millimeter per injection. And there are several best practices that we can talk about and technique tips. And I'll just cover a few, and these will be important to discuss as we get into administration in your practice. So beginning with the foot, injecting slowly to prevent spill, avoiding gangrene proximity. The goal is to cover the entire ischemic tissue. It takes about 20 to 30 minutes. Post-injection, monitoring for 2 hours, releasing the patient if stable. And then, for the first 5 patients, we're going to recommend several hours of observation plus phone checks so that every physician can get comfortable with the administration process. You could lay eyes on the patient to make sure that they have received a safe administration. And they're comfortable in leaving the physician's office. Local anesthesia or analgesia is important, and we can talk more about that. Safety monitoring and follow-up visits on days 1 to 30, 60, 90, 170, and then following for up to 12 months is important, mainly because we want every physician, again, to really see the impact of the therapy, if it is working or not working, and if it's working, to observe the healing process and observe any other risks relative to that patient, whether they are candidate or not for further amputation as the treatment takes effect. Okay, so we'll keep going here. Thank you for bearing with me through some of those details. It's very important, and I'm sure you'll have many questions that we can cover off on as we go through. So, why is Florida important? In the law itself, they recognize the value of stem cell therapy that is safe, that is effective. They recognize investigational treatments for compassionate use, and they recognize that if a patient is with a physician that stays in their area of expertise, they provide informed consent, and the patient knows that it's an investigational therapy, that for patients with end-stage peripheral arterial disease at risk of an amputation, with wounds that won't heal, Florida deems that this therapy may be considered with very specific conditions. And so, we live and breathe the details of that this piece of legislation. We encourage you to take a look, and we can provide you a copy. We've covered a little bit of the manufacturing process of the cells, the blood collection, a simple 250 ml blood draw from each patient. We've talked about the cell culturing, in our clean room, safe return of those cells to the physician and pre-filled syringes, and the treatment administration itself. This is a typical workflow where a patient could be referred to you. In the case of vascular surgeons in the state of Florida, you're able to administer the cells in your own practice, and we think that is ideal, where you can manage and control the cell delivery process. You can then see the patient, monitor the patient, see the results yourself. And then Hemostemix also provides patient support and patient navigation. If the patient needs help and understanding travel. If they're coming in from a travel tourism perspective, if they need help finding lodging or finding a physician, we can help refer them to you. And then also we help with access to care, which is one of the most important features. We know that ACP01 is not yet FDA approved. There's not payer reimbursement. And we are working day and night to provide every possible way to help patients afford therapy. The main way is through our treatment convertible debentures. And so that really is in the case of investors in Hemostemix that would like to reserve therapy. And meanwhile, there's a 6% interest paid on that investment. And that goes to the manufacturing of the cells. And then treatment can be scheduled whenever it is appropriate for that patient going forward. Second, there is out-of-pocket payments. We have several financing partners that help provide low monthly payments for patients. It's about a car payment, and it is roughly a 3 to 4 year term, and that's generally mapped to the costs of care of not receiving the stem cells. And the way we have looked at it is that it's around $300,000 to $400,000 for a patient who does not receive the appropriate care, and then our manufacturing cost is $37,000, and that's the out-of-pocket costs that we can then come in to support with financing around $800 a month is what is the typical payment. We also have 501c3. It's a foundation that we've started for patients that need care and cannot afford it. We encourage our affluent patients to make a donation to the 501c3 to help patients who need access support. So just to summarize, the manufacturing cost is around $37,000 for a treatment of ACP01. And we can support that with around $800 monthly payments is what is expected from a financing perspective. We will talk a lot and continuously about our phase 1, 2, 3 studies, our IRB solutions to get to full patient access, which we expect to come in the near future. We typically have many questions at this point, and this is the last slide of the presentation. The questions that we often get are, who qualifies for ACP01? How do we safely administer ACP01 of the stem cells? What are the costs and insurance solutions? And so, we encourage you please to get in touch with me or anybody else on the Hemostemix team. You can email me directly at clawrence@hemostemix.com, or please add comments to the chat. We look forward to all of your questions and solutioning with you to bring what is an exciting and transformative solution to market. And we just thank you for your attention and your time. Thank you again for reaching out. We host the VesCell Health Talks weekly, sometimes bi-weekly based on our travel schedules, but we encourage you to come back. And also please go to the Hemostemix YouTube channel. We've just completed a fantastic grand rounds with a very thorough scientific review where we field a lot of questions as well from a wonderful team of vascular surgeons. So thanks again, everybody, for listening in. We look forward to being in touch and appreciate your time. Have an excellent day, and we'll see you soon. Please come back and see us. Thank you.